Okay, so when we're talking about migraines, migraines are probably the highest yield, I would say, of all of the headaches that we're talking about. So these are pretty important. And one thing that comes up a lot on step one are mechanisms. And, with migraines, the interesting thing is that the actual mechanism isn't, really well elucidated, but it still comes up pretty frequently on step one. So let's talk about that. So the way this works is, you have some increase in central nervous system excitability, and there's spreading of this excitability and different depolarization throughout the cortical membrane, okay? And that eventually leads to this abnormal activation of trigeminal fibers. Now, this is particularly high yield. Now, another way that they can say this is they can say instead of fibers, they can put the term afferents here, okay? So they can say trigeminal afferents. Okay, so this is kind of the wording that they use for this. But in any case, there's some abnormal activation of these fibers in the meninges, okay? And then that causes a release of this thing here, CGRP. Okay, now CGRP is also known as calcitonin gene-related peptide. So CGRP, if you remember, we talked a little bit about substance P before. So it's kind of similar to substance P in that these are both going to be vasoactive peptides. Okay, so both of these are vasoactive peptides. Okay, so what is a vasoactive peptide? Well, it's acting on the vessels. Primarily, this is going to be causing vasodilation. Again, CGRP, substance P, right? Those are going to cause vessels to dilate, right? In the intracranial vessels specifically. And so that dilation is thought to somehow promote some of the plasma protein from leaving the blood vessels or plasma protein extravasation, along with neurogenic inflammation. There's inflammatory mediators that can get out into the interstitium and then cause potentially some of this pain. So the bottom line, the thing that you need to know is that in migraine, there is an abnormal activation of trigeminal fibers or trigeminal afferents, leading to release of substance P and calcitonin gene-related peptide. If I only had enough room in my brain to remember one of these, I would remember the calcitonin gene-related peptide. And remember, this causes vasodilation. Migraines, vasodilation is what causes the symptoms, and that's why when we treat migraines, what do we use? We use vasoconstrictive agents. It's important to remember that. Okay, and again, you can remember vasodilation is really associated with inflammatory responses because we're making the blood vessels more permeable to allow these inflammatory mediators to get out into the interstitium. That's the concept, okay? So that's the pathophysiology for migraine, and that's particularly important to remember. Okay, let's clean this up a little bit. Okay, now let's just talk about the presentation in general here. So when we talked about tension headaches, what did we say? We said that the tension headaches were classically going to be bilateral, right? Bilateral, band-like. In migraines, they're classically going to be unilateral. And again, it's these descriptive terms that you want to remember. Pulsating, throbbing, very classic for migraines. And the big thing with migraines too is that usually in a board question, they're going to give you some aura. Now, aura will generally precede the headache. It can happen with the headache, but usually it'll be some kind of, neurologic symptom. The patient might have, arm numbness or visual disturbance. And, the most classic kind of aura actually overall is going to be some kind of visual disturbance. And it could be, flashing lights. Okay, it could be the scintillating scotomas, which this is an example of these scintillating scotomas. So as you can see this kind of arc-shaped scotoma here in this person's visual field. Okay, and usually they'll start centrally and they'll kind of shift off to the end of the field. And so the patients will kind of complain of these, color variations, or like I said, it'll be flashing lights or zigzag figures, blurriness of vision, anything like that would be very classic for the aura. And then it's reversible, right? So they're going to have these symptoms, but then those symptoms are going to go away, and then all of a sudden they're going to start to experience a pretty severe headache, typically a unilateral throbbing or pulsating headache associated with photophobia. This is very classic. So the patients will usually be, in a very dimly lit room, right? With tension headaches, we didn't really see a lot of this. We didn't see a lot of nausea. We didn't see a lot of emesis, right? We didn't see the aura. So these are all the things you can put together to kind of differentiate tension headaches from migraines. Again, they're very different if you're comparing these things. It's not like there's one thing that helps differentiate them. I mean, there's many different things in the presentation to look for. And in the duration, these are usually going to be 4 to 72 hours. Now, we talked about tension headaches. We said tension headaches can really be any duration. Okay, so that doesn't help you necessarily differentiate migraines from tension headaches, but you'll see in a moment that cluster headaches typically will happen in a much shorter duration, but more regular association, every day. You might have a cluster headache every day at the same time. So that's going to be different from migraines. And then, trigeminal neuralgia, that can happen 100 times a day. It's going to be very short. Okay, but this is going to be a bit longer, 4 to 72 hours. I just want to jump down here to associations. There is a genetic predisposition. So in board questions, there'll be a family history of migraines, usually. And this is where the association is really important. This is very classic in women. Almost always when you get a migraine question, it will be in a female. Not every time, but most of the time. It's very classic to be asked about in females. And again, there's overlap here with some of the triggers. Alcohol, nicotine might also be triggers for migraines, although not as high yield. Now, one thing you might be thinking about is, okay, well, I get that, but how do I know that this patient isn't having a stroke, right? Because you have neurologic symptoms. Now, when you have a stroke, typically we're looking for motor symptoms. We're looking for motor deficits, right? The patient is unable to move the left side. They have facial drooping, something like that. You're not going to see that with migraines, okay? At least not with a classic migraine. And so that's something that's pretty important. And again, when you do imaging of the brain and you do MRI, CT scan, it's going to be negative almost always in a board question on a patient when they're asking about migraines. Okay, so reversible neurologic symptoms, but we're not talking about motor symptoms. We're talking about, like I said, classically visual disturbances, maybe sensory loss. Again, temporarily reversible, resolves on its own. So like I said a moment ago on step 1, you don't really have to distinguish which drug to use, at least not anymore, but you do have to know the mechanism of action. And so, for example, they can tell you in a board question, hey, we treated a patient with a migraine with sumatriptan or ergotamine, right? They can tell you that we treated a patient with one of these drugs, and you have to know the mechanism of action. Usually they'll ask, what's the mechanism of action? So let's talk about that for a little bit. So sumatriptan acts on these serotonin receptors. So remember, 5-HT is 5-hydroxytryptamine, right? That's serotonin. So sumatriptan is going to act on these receptors as an agonist. Now, in doing that, it's going to have a couple of effects. One of the effects is that it can inhibit this calcitonin gene-related peptide, right? We just talked about this is part of the reason why we have this inflammatory response, right? So sumatriptan does two things. Number one, inhibition of CGRP. The second thing is it can bind to the smooth muscle cell tissue in the brain, causing vasoconstriction. So these are both countering the effects that we have with the pathophysiology of migraines. Okay, so sumatriptan is used classically in migraines for acute abortive management of the migraine. Okay, so that's particularly high yield to remember. And again, it's important to remember, serotonin agonist, inhibition of CGRP, and it causes vasoconstriction. Now, the ergotamine and some of its variant derivatives here also have similar effects. They also have adrenergic activity, okay, and they also eventually can lead to vasoconstriction. Now, one thing that I want to say, you have to be very careful here. You don't want to be in a situation where you give sumatriptan with certain other drugs, okay? So let's talk about that. On step 1, they might give you a migraine patient, and they might tell you the patient was treated with sumatriptan, and then they might ask you about some of the side effects of the drug that the patient was treated with, and you have to be familiar with the side effects, the side effect profile of these drugs. So the first thing, so we're talking about sumatriptan here, okay? So sumatriptan. So the first thing, let's go number 1. Number 1, you don't want to give this with ergotamine, okay? Because the thing is, you can imagine if you're causing vasoconstriction, right, with two different drugs, particularly one that has alpha adrenergic activity, right, alpha-1 adrenergic activity, this can lead to a significant rise in the blood pressure. Okay, so that's one of the major side effects. It's going to be hypertension. And if you give it with ergotamine, that's really going to kick your pressures up, right? You don't want to do that. The second thing is we have to watch out for serotonin syndrome. Okay, so that's the second thing, serotonin syndrome. And I know I kind of talked about this a little bit before. Remember, this is a serotonin receptor agonist, right? So there's certain drugs that we said before that can cause serotonin syndrome, right, if they're given in conjunction. So for example, right, if I gave an SSRI, right, fluoxetine, right, for example, and I gave a monoamine oxidase inhibitor, particularly a monoamine oxidase inhibitor that's non-specific, right? We're not talking about selegiline, which is primarily targeting dopamine. We're talking about something that's non-specific because both of these are going to cause more serotonin to be in the synaptic cleft. And if I give that with a serotonin agonist, right, that's going to cause an even higher level of serotonin, potentially leading to serotonin syndrome. So we want to give this cautiously with a patient that's on SSRIs or monoamine oxidase inhibitors, okay? So when they're telling you the medications that the patient is on, and then they tell you, okay, we've given this medication, and they ask you, what is this patient at risk for? What are the major side effects, right? You have to be able to kind of integrate that. So that's the second thing. Finally, third thing, this is probably the least high yield. This is why I'll mention it last here. With sumatriptan, it's also teratogenic. Okay, and so is ergotamine. And the reason, this should make sense to you, right? So you have your placenta, right, that's supplying nutrients and oxygenation to the fetus. If you start giving vasoconstrictive agents, or if a mom's taking cocaine, for example, right, that's going to decrease the blood supply going to the fetus. It's going to bring down, their ability to absorb those nutrients and get oxygenation. So that's also something to be on the lookout for. So these are the three things. I like to think of things in three because it's like the optimal number to remember information. These are my big three things for sumatriptan. Now, one thing that, comes up, and this is more of a step 2 thing, but sometimes comes up on step 1, is you have to know that, all this stuff that we're talking about, this is all, acute management. So sumatriptan, ergotamine, this is all acute management. So it's not, if somebody has a history of migraines, but they're not actively having one, you can say, okay, well, is there something I can give them to prevent future migraines? And the answer is, yeah, there is certain medications you can give. And, some of those medications for migraines are topiramate, okay, which is classically going to be an anti-epileptic drug. Okay, so there's topiramate. There's beta blockers, right? You can give beta blockers like propranolol, for example. You can give amitriptyline, right, which is a TCA, tricyclic antidepressant. So these are all, sometimes classically used for migraines. The reason I bring this up is because when we're talking about cluster headaches, there's also preventative management. But again, it's not any of these three drugs. For cluster headaches, it's verapamil, which is a calcium channel blocker. And I'll talk about that in the next slide. But these are 3 preventative drugs just to keep in mind if you have some extra space up there for migraines. And the last thing is, I just put this on here. This is an acronym. So pulsatile, right? That's one of the key classic words to describe migraines. And then 1 day duration, right? Usually about 1 day duration. It can be a little bit longer, up to 72 hours, but it's around the 1 day duration mark. And this is longer than cluster headaches. It's longer than trigeminal neuralgia. Let's just put an approximately sign here, approximately 1 day duration. Again, it can vary a little bit. Classically going to be unilateral. There's nausea and emesis can be seen in these patients, right? And it's usually very debilitating. Like I said, these patients will prefer to be in a very dark, dim lit room, typically very quiet room. Okay, so pound. So that's one way to kind of remember some of the presentation here with migraines.